What I'm about to share is something most cardiologists know but rarely say out loud in a 12-minute appointment. If you're over 60 and taking blood pressure medication right now, the next 18 minutes could explain why your numbers still aren't where they should be, or why you feel more tired, more dizzy, more off than you did before you started the pill. This isn't a video telling you to stop your medication. Don't. But it is a video telling you 3 things your cardiologist almost certainly didn't mention. 3 things that determine whether your medication is working at 50% strength or 90% strength. The third one is the one most patients have never heard. Stay with me to the end, because if you remember nothing else, you'll want to remember that one. Here's why this matters now. Roughly 70% of Americans over 65 are on at least one blood pressure medication. And in my 30 years working with patients in that age group, I've seen the same pattern again and again. A patient comes in, their pressure is still 145/90, the cardiologist adds a second drug, then a third. By age 70, they're on 4 pills and feeling worse than ever. It's not the patient's fault. And it's not really the cardiologist's fault either. The system gives them 12 minutes per visit. There's no time to explain how these drugs actually behave in a 65-year-old body versus a 45-year-old one. So they don't. They write the prescription and move on. That's what we're going to fix today. 3 things your doctor didn't have time to tell you. And by the end, you'll understand your medication better than 95% of the people taking it. Let's start with the most fundamental one. The one that surprises my patients the most. The first thing your cardiologist probably never told you is this. Nearly every blood pressure medication on the market today was originally tested on adults under 60. Read that again. The drug you're taking, whether it's lisinopril, amlodipine, losartan, hydrochlorothiazide, or metoprolol, the foundational clinical trials that got it approved were done predominantly on people in their 40s and 50s. A landmark analysis published in the Journal of the American Geriatric Society reviewed 109 major hypertension drug trials. Only 14% of participants were over 65. Almost none were over 75. Why does this matter? Because a 45-year-old body and a 70-year-old body process these medications very differently. The kidneys filter slower after 60. The liver metabolizes drugs differently. Body composition shifts, less muscle, more fat, which changes how a medication distributes through your tissues. And the blood vessels themselves become stiffer with age, which means they don't respond to certain drug classes the same way. Here's a real example. Margaret, 71, lives outside Phoenix. Her cardiologist put her on amlodipine 10 milligrams, a standard starting dose for adults with high blood pressure. Within 3 weeks, Margaret's ankles were so swollen she couldn't fit into her shoes. She was dizzy when she stood up. Her blood pressure had dropped, yes, but to 105/62, which in a woman her age caused 2 near falls in her kitchen. What happened? Amlodipine works beautifully in 50-year-olds, but in older adults, especially women, the same dose often produces stronger effects than the trials predicted. Margaret's body wasn't broken. The dose was wrong for her age. When she came to see me, we cut her dose in half and added a small dose of an ACE inhibitor at a different time of day. 6 weeks later, her reading was 132/78. The swelling? Gone. The dizziness? Gone. Here's the part that might frustrate you. There's something called the STEP trial, short for Strategy of Blood Pressure Intervention in the Elderly Hypertensive Patients. It was published in the New England Journal of Medicine in 2021. It was one of the first major trials to focus specifically on adults 60 to 80. And what it found shifted the conversation. In that age group, an intensive target around 110 to 130 systolic produced better outcomes than the older, more relaxed targets, but only when the medications were dosed carefully and adjusted for age. The key phrase there is dosed carefully. Most patients over 60 are not. They're handed a prescription that was calibrated for someone 20 years younger. If you've ever told your doctor, "This medication makes me feel awful," and the response was, "Give it more time," you're not crazy. You're not being dramatic. Your body may be telling you the dose is wrong for your age. That's a conversation worth having at your next appointment. Not stopping the medication on your own. Please don't do that, but bringing this up directly. Now that you understand why dosing for seniors is its own science, the next question is even bigger. When, exactly, is your blood pressure medication working hardest? And when is it weakest? Because there's a window in every 24-hour cycle when your medication's grip is at its lowest. And that window happens to be exactly when most strokes occur. Here's the second thing your cardiologist almost certainly didn't tell you. Most blood pressure medications have what's called a trough, the lowest point in their daily effectiveness, and for the most commonly prescribed drugs, that trough lines up almost perfectly with the most dangerous hours for stroke and heart attack. Between roughly 4 a.m. and 9 a.m., two things happen at once. Your body's natural cortisol rises in preparation for waking. Blood pressure climbs, sometimes by 20 to 30 points. And if you took your medication the night before or first thing in the morning, you're now in the lowest concentration window of that drug in your bloodstream. The drug is the weakest, the pressure is highest. Wrong combination. A study from the University of Vigo in Spain, the Hygia chronotherapy trial, followed over 19,000 hypertensive adults for more than 6 years. Half took their medication in the morning, half took it at bedtime. The bedtime group had a 45% lower risk of cardiovascular death, stroke, and heart attack. 45% from one change. Same medication, same dose, different times. That study had its critics. Some researchers questioned the methodology, but several follow-up studies, including work from groups at Harvard and Vanderbilt, have shown similar trends. For many adults over 60, especially those with what's called non-dipper blood pressure, where pressure doesn't drop at night the way it should, bedtime dosing changes everything. But, and this is critical, not every medication should be taken at night. Diuretics, the water pills like hydrochlorothiazide, will have you up to use the bathroom 3 times before sunrise. Some beta blockers can disrupt sleep architecture if taken late, and certain ACE inhibitors work better with food, which complicates evening dosing. This isn't a decision to make alone. This is a conversation to have with your doctor or your pharmacist. Walk in with this exact question. Based on my specific medications and my morning blood pressure readings, would I benefit from moving any of these to bedtime? If you're still watching, this next part is the most important. Most people drop off here, but if you stay with me for the next 5 minutes, I'm going to show you the single factor that determines whether your medication works at 50% strength or 90% strength. It has nothing to do with the pill itself. Before that, there's one more thing about timing. Your morning blood pressure reading, the one you take when you wake up, before coffee, before getting dressed, is the single most predictive number for your long-term heart risk. Not the reading at the doctor's office, not afternoon reading, the morning one. A 2019 analysis in the journal Hypertension followed 8,000 adults over 60 for 10 years. Those whose morning readings stayed elevated had more than double the rate of stroke, even when their daytime averages looked normal. If you're not measuring your blood pressure at home, specifically in that first 30 minutes after waking, you're missing the most important data point about your own health. Buy a validated home cuff. The brand matters less than getting a model that's been validated on the lists published by the American Medical Association. Take your readings sitting down, feet flat, arms supported at heart level after 5 minutes of rest. Same time every morning. Write it down. Bring those numbers to your next appointment. Those numbers, your morning readings, over time, are what tell your doctor whether your medication is actually doing its job. The number at the doctor's office is unreliable. White coat hypertension is real. Office readings are often 10 to 15 points higher than your true average. Doctors who only ever see the office number are flying blind. Now, the third thing, the biggest one. The thing your cardiologist almost certainly didn't tell you because he or she didn't have time. But you're still here. You're watching at minute 12, so I know you'll listen. The third thing, the most important thing, is this. There are 4 specific inputs that determine whether your blood pressure medication works at 50% of its potential or 90% of its potential. Same pill, same dose, 2 completely different outcomes. And it has nothing to do with the medication itself. I'm going to show you exactly what these 4 are in order of impact, drawing on data from the PURE study, the prospective urban and rural epidemiological study, which followed over 150,000 adults across 17 countries for more than a decade. One of the largest cardiovascular studies ever conducted. The findings are clear. Input number 1, sodium and potassium balance. Not just sodium, the ratio between the two. The average American over 60 consumes about 3,400 milligrams of sodium per day and only 2,200 milligrams of potassium. The ratio is wildly off. A study published in the New England Journal of Medicine showed that shifting that ratio by replacing some sodium with potassium-rich foods like bananas, sweet potatoes, white beans, spinach, and avocados can lower systolic blood pressure by 5 to 8 points. That's the equivalent of adding a low-dose second medication, without the side effects. A note here. If you have advanced kidney disease, or you're on certain medications like spironolactone or some ACE inhibitors, potassium can be dangerous in high amounts. So this again is a conversation with your doctor. Don't go buy a potassium supplement at the drugstore. Eat the food. They're safer and they work. Input number 2, sleep quality. This one almost no cardiologist mentions. A 2022 study from the University of Arizona found that adults over 60 who slept consistently fewer than 6 hours had blood pressure that was 8 to 12 points higher on average, even when fully medicated. Sleep is when your cardiovascular system resets. If sleep is disrupted, the medication is working against an uphill current all day. Sleep apnea is the silent driver here. Estimates suggest that around 60% of adults over 65 with treatment-resistant high blood pressure have undiagnosed sleep apnea. If your spouse says you snore loudly, or you wake up gasping, or you're exhausted by mid-afternoon despite a full night in bed, get evaluated. A simple home sleep study can confirm it, and treating it may drop your blood pressure 10 to 15 points on its own. Input number 3, movement timing. Not exercise, movement. Specifically, what happens in the 30 minutes after eating. Research from the Mayo Clinic showed that a 10-minute walk after each meal, just 10 minutes, light pace, lowered post-meal blood pressure spikes by an average of 14 points. 3 short walks per day. No gym, no sweat, just movement at the right time. Most patients are told to exercise more. That's useless advice. Specific is what works. 10 minutes after meals. That's it. If you do nothing else from this video, do that. Input number 4, and this is the one that surprises everyone. Slow breathing. Specifically, 6 breaths per minute for 5 to 10 minutes a day. This is sometimes called device-guided breathing, and it's been studied at multiple major institutions, including the Mayo Clinic and the Cleveland Clinic. The American Heart Association has endorsed it as a non-pharmacological supplement to blood pressure treatment. Here's why it works. Most adults breathe 14 to 16 times per minute. Slowing to 6 breaths per minute, a 5-second inhale, a 5-second exhale, activates the parasympathetic nervous system, which actively lowers blood pressure through the vagus nerve. Studies have shown systolic reductions of 6 to 10 points after 8 weeks of consistent practice. No side effects, no cost. I want you to try this right now with me. 5 seconds in through the nose. 5 seconds out through the mouth. Do that for 5 minutes every morning, just 5 minutes. After 30 days, take your blood pressure reading and compare it to today's. The 4 inputs together, sodium-potassium balance, sleep quality, movement timing, and slow breathing, are what take your medication from working at half strength to working close to its full potential. Same pill, same dose, different body to act on. Carol, 68, in Sarasota, came to me last year on 3 medications. Her reading was still 148/92. We didn't change a single one of her medications. We changed the 4 inputs. 12 weeks later, her reading was 124/76. Her cardiologist asked her what she'd done. She told him. He said, and I'm quoting her, "I wish I had more time to talk to patients about that." That's the gap this video is trying to fill. Here's exactly what I want you to do this week. 4 steps. None of them stop your medication. All of them are to talk to your doctor first. Step 1. Buy a validated home blood pressure cuff if you don't already have one. Take your reading every morning for the next 14 days. Same time, same conditions. Write the numbers down. This is the data your doctor needs. Step 2. At your next appointment, ask one specific question. Given my age and my medications, would any of them work better at bedtime? Bring your 14 days of readings. Let your doctor make that call. Don't change the timing on your own. Step 3. Start the 4 inputs gently, 1 per week. Week 1, add potassium-rich foods. Week 2, add the 10-minute walk after meals. Week 3, add the slow breathing practice. Week 4, get evaluated for sleep apnea if there's any reason to suspect it. Step 4, in 90 days, recheck your readings. Bring them back to your doctor. The numbers will tell the story. A reminder, and this is important, nothing I've shared today is medical advice for your specific situation. It's general information based on published research. Your doctor knows your history. Talk to them before you make any changes. If you've been on the same medication for years and it's been working well, that's a win. Don't disrupt it without guidance. But ask the questions. You're allowed to ask the questions. Linda and everyone watching, your heart has been working faithfully for you for 60+ years. It's not too late to give it the help it actually needs. The medication is part of the answer. It's not the whole answer, and nobody else is going to tell you the rest of it in a 12-minute appointment. If this helps you, you'll want to see next week's video, the morning routine that's been shown to reduce cardiovascular events by 32% in adults over 60. There's one specific 20-minute sequence backed by 3 major studies, and I'll walk you through every step. Until then, take care of your heart. It's the only one you have. I'll see you next week.